Hey everyone, and welcome back to The Explainer. I am absolutely thrilled to have you joining us today. If you're the kind of focused learner who loves mastering complex topics through really clear, structured visuals, well, you're in exactly the right place. Today, we're stepping into the truly fascinating world of homeopathic case analysis. We're going to directly explore the historical methodologies used to decode really complex patient cases. Honestly, it's a lot like being a medical detective. We're going to look at exactly how practitioners historically gathered, ranked, and analyzed all their clues to solve these medical mysteries. So, here's the good question. How do you find the right remedy when a patient presents with 20 different seemingly chaotic symptoms? I mean, it's a fantastic question, right? Imagine someone just dumps a massive, disjointed pile of patient clues right on your desk. How do you take all that noise and transform it into a clear, unified solution? That right there is the exact problem we're going to solve in this explainer today.
Okay, let's dive into this. Here's a quick look at our roadmap. We've got 5 stops: signs, symptoms, and reliability, building the characteristic portrait, Kent's hierarchy of symptoms, Boenninghausen's complete symptom, and finally, integrated clinical analysis. We're going to break all these historical methodologies down into really manageable filters.
All right, let's kick things off with section 1, signs, symptoms, and reliability. Because before we can even think about solving the puzzle, we absolutely have to gather and verify our raw data. Now, there is a super crucial distinction we need to establish right out of the gate. Symptoms on one side and signs on the other. Symptoms basically communicate the patient's subjective experience. What they're feeling, the sensation, how it's impacting them day to day. Signs, on the flip side, are objective data. They come directly from your clinical observation, physical exams, or exact measurements. And while both are absolutely vital for diagnosis, the number one rule from our source material is this: neither of these should ever be replaced by a clinician's speculative interpretation. We've got to stick to the facts. So how do we filter these clues based on their reliability? Well, a reliable symptom is spontaneous, it's clear, it repeats, and it just makes chronological sense. An uncertain symptom, though, that's usually vaguely described, it keeps changing, or, and this is the absolute worst, it was suggested by the interviewer. And here is a really fascinating takeaway from the text. Reliability is absolutely not the same thing as intensity. A super mild but spontaneous and precise symptom is actually a much better clue than some highly dramatic symptom that the clinician accidentally planted in the patient's head.
Which brings us right to section 2, building the characteristic portrait. Now that we actually have our verified clues, how do we group them in a way that makes sense?
And this brilliantly illustrates what we call the totality. The totality is an organized portrait of the perceptible disease state. It is not, and honestly, this is absolutely critical to remember, it is not just some unorganized inventory or a random shopping list of all the symptoms. Having more symptoms does not automatically give you a better case. The whole goal here is careful selection and synthesis so you can create a true portrait of the patient as they are uniquely affected by the disease.
To actually build that portrait, we have to look at the contrast between two types of symptoms: common versus characteristic. Common symptoms are exactly what you'd expect to see in a given diagnosis. They're shared by tons of patients, which means they have very low differentiating power. Characteristic symptoms, on the other hand, these are unusual, they're highly reliable, and they completely individualize the expression of the disease. So, while common symptoms are great for monitoring severity, the characteristic clues are the ones that actually point you to the specific, unique culprit behind the patient's illness.
And that brings us to Samuel Hahnemann's foundational principle, which he famously outlined in section 153 of the Organon. Hahnemann tells us to focus intensely on the striking, singular, uncommon, and peculiar features. We usually just abbreviate this as PQRS. These peculiar features are your key memory aids. They literally command your attention because they stand out so much in intensity, clarity, or just their unusual expression. And they point directly to the individualizing quality of that specific case. Building right off of Hahnemann, we arrive at section 3, Kent's hierarchy of symptoms. James Tyler Kent brought in a framework to actually rank our clues by importance, moving from the whole person all the way down to the local part.
Let's walk down this hierarchy together. Kent basically organized symptoms into 4 strict levels: mental generals, physical generals, characteristic particulars, and common symptoms. The symptoms at the top, the generals, represent the patient as a whole person, which means they carry the absolute highest analytical weight. Let's look a little closer at that top tier. A mental general represents the absolute highest level of the person. We're talking about clear, distinct changes in emotion, intellect, will, or behavior.
something like a profound anxiety or suddenly developing a fear of death. But the texts do give us a serious warning here. We have to be really careful to distinguish an enduring personality trait from an actual disease-related change. You never, ever want to reduce your patient to a simple stereotype. Stepping down to level 2, we hit physical generals. Unlike a localized pain in one spot, these describe broad bodily reactions that affect the entire organism. We're looking at things like a patient's overall thermal preference, like are they just always freezing, their thirst, their sleep patterns, their overall energy levels. These are incredibly vital because they describe how the whole person is reacting rather than just zooming in on one isolated anatomical part. Let's actually see how this builds using a really practical example from the source text. Imagine a case file of a 35-year-old patient who's dealing with chronic migraines. Kent's hierarchy filters all that clinical chaos beautifully. At level 1, our mental general, we note the patient has this intense anxiety about their health. At level 2, the physical general, we record that they have extreme bodily chilliness that actually gets much worse in a cold wind. And finally, way down at level 3, the particular, we log the actual right-sided temporal pain. Do you see how we move from the whole person all the way down to the specific local headache? It's pretty amazing. All right, moving right along to section 4, Boenninghausen's complete symptom. If Kent's method was our wide-angle lens for the whole person, Clemens von Boenninghausen's structural methodology is our magnifying glass to ensure no specific detail is missing. Boenninghausen insisted that a local symptom is clinically incomplete until it passes through 4 interconnected pillars. Number 1 is location, the exact site, side, and depth. Number 2 is sensation, the qualitative feeling, ideally using the patient's exact words. Number 3 is modality, what specifically aggravates or ameliorates the symptom. And number 4 is the concomitant, or the accompanying symptoms. Now, what's really, truly fascinating here is this concept of the concomitant. The text defines it as an accompanying complaint that happens right alongside the chief complaint, but it has absolutely no direct anatomical or physiological connection. Seriously, this is the secret weapon of case analysis. Concomitants are absolutely brilliant at taking these otherwise vague, fragmentary complaints and completely individualizing them. Let's apply Boenninghausen's 4 pillars directly back to our migraine patient to see this in action. We'll take that fragmentary level 3 particular symptom from earlier, and we're going to complete it. Location, right temple. Sensation, a throbbing pain. Modality, it actually gets better from applying firm pressure. And the concomitant, uncontrollable yawning during the headache. Just look at that. A super common headache has just been transformed into a rich, highly individualized symptom. And that brings us to our 5th and final section, integrated clinical analysis. How does modern clinical practice actually bring all of these historical detective methods together? Well, this right here is essentially your ultimate clinical cheat sheet. Modern practice actually synthesizes all 3 of these traditions. Samuel Hahnemann provides the philosophical focus. He's the one identifying those peculiar, uncommon PQRS characteristics. Then James Tyler Kent gives us the weighting system, ranking those symptoms from the whole person all the way down to the local parts. And finally, Boenninghausen gives us the structural completeness, making sure every single fragment is fully built out with location, sensation, modality, and concomitant. So, the absolutely crucial point here is captured perfectly in this clinical insight from the text. Use symptom hierarchy flexibly. Do not apply rigid rules mechanically. This is so important. While Kent places mental generals at the very top, the integrated approach tells us that a highly peculiar physical general or a perfectly complete local modality can sometimes carry decisive weight. You literally have to use your best clinical judgment. It's an art as much as a science. And that leaves us with a final, slightly provocative thought to wrap up. Have you mastered the art of observation enough to see the complete portrait hidden within the symptoms? Today, we've covered exactly how to verify reliability, build a totality, rank everything using Kent's hierarchy, and complete it all using Boenninghausen's pillars. So I challenge you to take these 3 analytical lenses, look right past the initial chaos of a case, and go solve the next medical mystery you encounter. Thank you so much for joining me on The Explainer today. Keep learning, stay focused, and I will see you next time.